What's going on, everyone? Today we are going to be continuing our conversation on the relationship between cardiac output and central venous pressure. Our cardiovascular system is a closed loop system, meaning that you really can only have blood in one of two places. That would be the heart or the vasculature. So ultimately, changes in the heart are going to impact the vasculature, and changes in the vasculature are going to impact the heart, because these are the only two places where blood is located in this closed loop, right? So the flow of blood is going to be determined by the amount of blood volume, the output of the heart, and then the properties of the vasculature. But when we look at steady state conditions at equilibrium, cardiac output and venous return must be the same, because simply put, if the heart, let's say, is producing 5 liters of blood per minute, well, then you have to make sure that that same amount of blood volume is ultimately returning back to the heart, right? So to put it in another way, the heart cannot pump what it does not receive. So if you're going to keep up with a certain output from the heart, there needs to be enough venous return, enough blood flow returning to the right side of the heart. Now, there may be a little bit of variability beat by beat, but ultimately the flow of blood will balance out, and there is, again, this equilibrium between cardiac output and venous return. And now, even though we're saying it as two separate terms, they're really describing the same exact thing. How much blood is moving throughout this entire closed loop system? Because again, it should be at equilibrium. Whatever is coming out should be pumped up, should be pumped back to the heart in order to keep up with that flow of blood. So, when we say venous return, there typically isn't a value with a unit attached to it. And so to describe this relationship, we typically will assess cardiac output and its relationship with central venous pressure or right atrial pressure. We've talked about this relationship in the past couple of videos, right? And so we talked about the cardiac function curve, which is how central venous pressure impacts cardiac output. Ultimately, the amount of blood pressure within the vena cava in the right atrium is ultimately going to determine the stroke volume and then therefore the cardiac output produced by the heart. So that's plotted as our cardiac function curve. However, if you wanted to plot the vascular function curve along with the cardiac function curve, we're going to need to violate how we normally plot things on a graph, because the vascular function curve is the inverse relationship, meaning that the central venous pressure is the dependent variable, which would normally go on the y-axis, and cardiac output would be the independent variable. So we're violating how we would normally plot the vascular function curve, if we wanted to plot it alongside the cardiovascular function curve. But this really describes the coupling between the cardiac function and the vascular function. So we know that things like myocardial contractility, blood volume, and total peripheral resistance can ultimately shift both the cardiac function curve and the vascular function curve. Therefore, they would also impact the functional coupling between the heart and the vasculature. So today we're going to look at, the normal functional coupling and then compare that to when someone's in a pathological state, like when they have a moderate or severe heart failure. When we look at the intersection of these curves, we see our typical operating point for our bodies, right? This is our equilibrium. This is the point in which cardiac output is producing here 5 liters per minute, and this central venous pressure of 2 is representing that steady state where the volume of blood returning to the heart is equaling the output, right? And there may be these small transient differences, but ultimately they balance out to this equilibrium. And if we have an event that occurs, ultimately, it can affect this functional coupling, like we said. So let's say point A would be an injection of venous blood accompanied with a removal of that same amount of blood on the arterial side. So we don't throw, so we're not changing the total volume of blood, but we're putting more blood from the arterial side to the venous side, right? And ultimately, what you're going to see then is a shift. So we're increasing central venous pressure. And due to that cardiac function curve, that increase in venous pressure is ultimately going to increase the cardiac output. So now, if we increased venous blood, right, during diastole, that's going to produce more cardiac output during systole. And if we produce more cardiac output, more blood is being pumped into the arteries. So we're increasing arterial volume now once the heart beats, and then that would decrease the venous blood volume, right? Because that blood they're coupled, they went from the veins, more venous blood went to the heart, and then the heart pumped it out to the arterial side, and that subtracted again from the venous side. And so now, since this point is above equilibrium, right, this is going to continue to fall as cardiac output continues to push out that extra blood. So ultimately, this balances back to the equilibrium. And so, like we said, there could be these small changes, but ultimately the system balances out. There is this equilibrium that is hit because the changes in the vasculature will impact the heart, and then changing, the output of the heart is going to then follow up by changing the vasculature. It's like I described in the last video. So basically what we said in this example, and it takes me a while to draw out here, but we're increasing preload, right? We're increasing the venous return, whatever you want to call it. We're increasing the amount of venous blood, right? And so that increases preload, which then increases cardiac output, right? But when you increase cardiac output, more blood goes into the arteries, right? And then less, if everything remained constant, less is in the veins, right? So ultimately, what cardiac output does now that it's increased is decreases preload. So now we're tying everything together. We talked about these two relationships independently, but now we're getting this cross-section. We're getting this functional coupling where changes in the vasculature impact the heart, and then those changes in the heart will further impact the vasculature. So now we'll talk about the effects of contractility, blood volume, and total peripheral resistance on this functional coupling. And so to drive the point home about contractility and blood volume, we'll be discussing what happens with acute and chronic heart failure. So we can see on this graph that we have our normal cardiac function curve and vascular function curve, right? So this would be a state, again, without heart failure and a normal level of blood, right? And so when you have acute heart failure, basically there's no change in blood volume, but what you're seeing is a decrease in contractility, right? So with a decrease in contractility, there is a decrease in stroke volume, therefore a decrease in cardiac output. And that's what you're seeing, this downward shift of the curve, the more severe the heart failure. So for a given central venous pressure, the heart can't produce, as much cardiac output. But, not only is the total cardiac output impacted, but this equilibrium point, this operating point, is shifted as well with acute heart failure. So with that decrease in contractility, less blood is getting out of the venous side. There is an increase in central venous pressure, and there is less cardiac output. And the more severe the heart failure, again, this downward and to the right shift, higher central venous pressure and then lower cardiac output. Ultimately, if the cardiac output decreases and more blood is in the venous circulation, there needs to be some sort of compensation, right? Because the heart isn't able to circulate as much blood throughout the system. That means less blood is going to be oxygenated and delivered to different organs of the body. And ultimately, mean arterial pressure is going to be impacted because this cardiac output is being impacted. So a compensation that typically occurs with chronic heart failure is that we get an increase in blood volume. And that is due to increase in fluid retention by the kidney. So by decreasing urine production and increasing water retention, that helps to increase blood volume, which helps to also increase cardiac output and blood pressure. So that's what we're seeing with chronic heart failure, is then by increasing blood volume, we get a shift. So even though the contractility has decreased, with moderate heart failure and then fluid retention, you could see near to normal, maybe cardiac output. But again, that comes at a price of a higher central venous pressure with an increase in blood volume. And in severe heart failure states, the increase in blood volume, does help to increase cardiac output a little bit. But you'll notice that it's not at the same level as normal, obviously, in a healthy human. And also we're dealing with this increase in pressure, in resistance, in the amount of blood volume that's in the systemic circulation. And ultimately, since in this severe heart failure, we're having a decreased ability to produce cardiac output, and we're putting more work on the heart. Ultimately, it could lead to congestive heart failure. Now, what's not shown on here is changes in total peripheral resistance. And when you have an increase in total peripheral resistance, that's due to vasoconstriction, right? So you have to think about how vasoconstriction ultimately will impact the vascular function and the cardiac function curve. Well, we look at the vascular function curve. We know that an increase in TPR, an increase in vasoconstrictions, means that there is going to be more blood on the arterial side and then less blood in the venous circulation, therefore decreasing venous return. And so that actually rotates the vascular function curve, but here it's depicted by this downward shift, right? So we see a downward shift here of that vascular function curve with an increase in TPR, and then an increase in TPR, and then an increase in TPR also impacts cardiac function as well. Vasoconstriction leads to higher arterial blood pressures, and that arterial blood pressure increases afterload, which decreases stroke volume. So what you see then is a downward shift of cardiac output as well. Okay, so that's also an increase in TPR. So that's the effects of resistance, and ultimately that impacts this intersection point. And so now this normal intersection point, when you get an increase in TPR, shifts downward, right? So ultimately, contractility, blood volume, and TPR all have effects on this functional coupling between the heart and the vasculature. So today we tied everything together. We talked in the past about how central venous pressure impacts cardiac output and how cardiac output impacts central venous pressure. And so today we really showed how interdependent the heart and the vasculature are and the functional coupling between the heart and the vasculature. So we described that relationship and talked about the normal intersection between these two curves. And then we talked about how things like contractility, how total peripheral resistance, and blood volume can ultimately impact this functional coupling between the heart and the vasculature. Thank you guys so much, and I'll see you in the next video.